have a wonderful panel discussion right now. May I request Dr. Rajesh Rajput, Dr. Jayashree Shwai, and Professor Manisha Sahay ma'am to switch on their camera, and then we can go ahead. Unfortunately, Mithun is not there, so any endocrine related thing I'll be asking to Rajesh sir or to Dr. Jayashree Shwai.
So, or else you can also answer from our side. Hello, Jayashree, how are you?
Hello.
So, Ashok sir wanted to tell something. Sir, you were muted. Sir, you were muted.
All the three talks.
Unmute, sir.
I unmuted now. The way Rajesh dealt the case is something new. All the three cases. And also, no, we had, when we said painful leg syndrome, we did not think that it will include restless at all. But, he beautifully developed the case and not only peripheral neuropathy and the second case and the first case, he developed the entire gamut. And Manisha is not here. Manisha is not here?
Yeah, she's there.
Manisha, as usual, Manisha, fantastic talk, fabulous talk. It's like a mathematics, no? Like a mathematics. It flowed one from the other. But I was just thinking that Manisha will talk about the perinephric abscess, which I'm not sure whether it is a urosepsis or not, but we'll come to that question, Manisha. And the last talk by Mithun, Mithun is always absolutely great in his talk, and this very
Mithun told that when discussion regarding sexual dysfunction keeps him engaged with the patient, but he didn't made it clarify the male patients or female patients. So that part is very important.
I think there are people live for three things in the world. One is food, second is wealth, third is. So I think in a lighter vein, what Jayan said is correct, but in a serious vein, Rajesh, that it's a very important part. So he said that when this part, food, wealth is already covered, when the sex part of the patient is covered, then they stay with him. That's what he meant. I remember one psychiatry who was giving their suggestion, what is called hypnosis. It becomes so successful, the wife will come to the psychiatrist to ask which fish to buy. So, susceptible to suggestion. So with this, may I hand over to the wonderful panelist and the moderator to take it forward. I think Amit has made wonderful.
Alok has also joined. Hello, Dr. Alok.
Alok is here. Alok?
Yeah. Hi, Alok.
Alok is there. The Jayashree, welcome. Now let Sambit start. Sambit has some.
Yeah.
Sambit, I leave it to you and to Shishir. Shishir Babu is also entirely, academic, and so please start. I will not take time.
Thank you, sir. Thanks a lot. So, welcome everyone to the panel. There were some questions which we have prepared, and also some chat questions which has directly come to us. So, first I will go to Rajesh sir, because that was a very wonderful talk and it was very practical also. Rajesh sir, even I have a problem, like for painful syndromes, we have so many drugs, but for painless and numbness limbs, what do you use actually, and what should be used? Because these are people who
see,
actually...
once patient develop numbness, and in layman terms, numbness means your peripheral nerves are now dead. Yeah. When a patient has pain, it means your peripheral nerves are crying. They are crying and giving you an indication. Please improve your metabolic control. Please improve your risk factors. And if we will do timely interventions, peripheral nerves will become silent. Shambit, there is also a curve. In that curve, until and unless the peripheral nerves are totally dead, means totally numb, and patient started feeling like something is between feet and the floor. जिसको हम बोलते हैं ना रुई का तक आ गया गद्दा पे, उस कंडीशन से पहले, if we treat diabetes aggressively, and as patient improves from slight numbness, there is an appearance of pain. There is a pain curve, and new appearance of pain in a patient who initially was feeling numb actually is again an indication that if we continue with going with the good metabolic control, this pain is going to disappear. So we have to very reassure our patient during that period of time that actually it's a good sign that initially you are not having any pain. With now good metabolic control, some pain has come. This is going to subside. It means your nerves are still alive. But if a patient, as you are saying, is totally having numb feet, dead feet, largely we cannot do anything. There are some studies where it has been shown that if these patients are vitamin B12 deficient or some other micronutrient deficient, addition of these may improve some velocities in nerve conduction studies, but largely there is no benefit.
Yeah, I think that's very clear that good metabolic control is important, and I think the role of vitamin B12, if at all, can be checked.
I again clarify. Actually, when we talk of vitamin B12, one has to understand that the normal levels of vitamin B12 varies from labs to labs. Cutoff even varies in different type of studies. If we see the levels of vitamin B12, clearly level less than 100 picogram per ml, vitamin B12 is deficient. More than 350 picogram, patients are sufficient. So if it is levels are more than 350 picogram, there is no benefit of vitamin B12. Now between 100 to 350 is a gray zone. Now in that, how to make a diagnosis? One simple way is to measure methylmalonic acid. If your levels of methylmalonic acid levels are elevated, these are actually early cases of vitamin B12 where vitamin B12 supplementation will help. Another very important thing to differentiate is between vitamin B12 and folate deficiency. Now, folate deficiency actually does not do peripheral neuropathy, but it is much more common than vitamin B12 deficiency. So if that is a scenario and patient has some degree of anemia, then simply measurement of homocysteine. Homocysteine levels are elevated in folate deficiency, but methylmalonic acid levels are normal. So there are ways where we can differentiate, but as in a common practice, our colleagues are doing, prescribing vitamin B12 to everyone, which not only increases the cost of prescription, but also add an unnecessary medication, is actually not benefiting the patients.
Thank you, Rajesh. I think
I have one doubt. In this contest, I have one doubt I want to clarify from Dr. Rajput. Sir, aldose reductase inhibitors has some role. Is there any role in these situations?
Excellent, excellent. Yeah, I will tell you. See, Jayashree, you're absolutely right. Aldose reductase inhibitor act on one of the pathways for 4 metabolic complications, 4 pathways which are given. And aldose reductase studies I have initially come from Japan actually. This molecule is approved in Japan, and that's how it is available in India. It has been shown that they are effective only in early neuropathy. If we are starting them late neuropathy, like what Sambit is asking, when feet are totally numb or dead, even aldose reductase inhibitor does not have a role at that point of time. So if they are started early in the disease, along with pain management, probably they are helpful because we are trying to address the natural defects of diabetic neuropathy.
Rajesh, that is the bottom line going around, that you should start ARIs much earlier. But Rajesh, you know, and I know that how early to start. You know,
that is $1 million question.
$1 million question. I just have one question to say that I'm just quoting Andrew Bolton, Sambit, that it is said that if there's a numb feet, only thing you have to do is to care for the feet, because pain or tingling numbness or the positive symptoms of neuropathy are God's gift to mankind. Once the feet becomes numb, it becomes absolutely at risk diabetic foot. So I think that point you also said in your lecture. So that's what I think Sambit answered your question. I know we have a host of 15 questions, so go fast. Next question.
Yes, so next question to Dr. Manisha ma'am. Actually, she has nicely told about SGLT2 inhibitor and urinary tract infection, but there are still doubts persist, and I just wanted some clarification from you about the role of SGLT2 in terms of UTI and in terms of the GMI or the genital mycotic infection. And if someone have recurrent UTI, what should be done? So someone is having recurrent GMI, what should be done? This for all the physicians who are listening.
So as I said, first baseline statement is that initially we were very, very scared about these SGLT2s because of the so-called risk of like glycosuria and infections and all that. But now studies have very clearly shown that it's not, UTIs are not that common, and even clinical experience shows the same. Mycotic infections are frequent. They may occur. They are increased about 3 times as compared to those patients who are not in SGLT2. And that itself also is an important problem. So how do we tackle that? Should we stop SGLT2? We should not stop SGLT2. We should counsel the patient about the genital hygiene. That doesn't mean that we stay clean and all that. We have to explain. We have to explain that every time you go for voiding, you have to wash the area thoroughly with water. Use cotton undergarments. Every 2 hours, go for voiding. Even if you don't want or do not have the urge to void, go and empty your bladder. If the urine is full in the bladder, you are more likely to have urinary infection. So at least 2 to 3 hours once, go and empty your bladder. Empty your bladder at bedtime as well. So these common things should be told to them. Then the method of cleaning, you shouldn't touch the hand which you have used to clean the motion, and you should not touch it to the urinary parts. So these small things need to be explained. We think the patients know about it. Many of them, they do not know about it. So this is quite important. And another important measure is circumcision. In some resistant cases where SGLT2 are mandatory in males, circumcision is also one option which reduces the incidence of these infections. And despite that, if still the genital infections continue to be a problem, then sometimes then SGLT2 has to be stopped. But that is not the preferred thing to do. As I explained, 90% of the times, if you are if you explain all these things to the patient very nicely, many of them, they respond to this. And sometimes we tell them like better to use Indian toilets, or do not sit in the toilet seat in a common area, like common toilets. Either they should clean the toilet seat and sit. Many of them, they just sit like that. Airports, those things. Now we don't have Indian toilets anymore. We have Western toilets. So we should use them properly. Clean the seat and sit. So all those small things need to be explained to the patient. And UTIs do not remain a major problem.
Yes, ma'am. I think that was quite clear that the relationship between SGLT2 and UTI is not there. At least all the bigger trials have told. Genital mycotic infection, definitely it is higher with SGLT2 inhibitor, and with proper genital hygiene, I think we can prevent that. Yes. So that should be the message. So coming to Jayashree madam, since Mithun is not there, I think in the last case he has told that patient has erectile dysfunction and the testosterone he has done, it was low. So how do you think the low testosterone is responsible for erectile dysfunction, and do you think that giving testosterone will improve the erectile dysfunction?
Yeah, it's a nice question. One interesting term is there, pardon. That means adult testosterone deficiency in adult. And it is the combination of the systemic deficiency, symptomatic, along with that the biochemical or hormonal testosterone deficiency. If the testosterone level is low, that is definitely a certain level, 2.5 ng or 2.3 ng per ml. In separate situations, in twice you have these low testosterone, then the patient is symptomatic. And the age, and after excluding that of the other causes like that of the thyroid, prolactin, and other things, and in that case you may go for if the hematocrit is permitting, and digital rectal examinations is good, and prostate specific antigen is permitting to you. In that case, you may go for the testosterone supplementations, and we have a close watch on that point of the hematocrit and the prostate specific antigens levels and the subsequent visit.
Right. Rajesh sir, you want to add something? Yeah.
Shambhit, testosterone deficiency in adult male is a totally different topic. And all testosterone which are low in an adult male need not to be treated.
Yes.
It is very clear. One has to understand that after 40 years of age, there is a natural decline in testosterone level, and there is a rise in SHBG level.
Yeah.
Now, because of which, if we measure free testosterone level, it is more rewarding. But unfortunately, there are some issues with free testosterone measurement, and we have to calculate it. Number two, SHBG has a number of other fallacies, like patient of diabetes are obese. Obesity itself causes increase in SHBG. Obesity causes change in leptin levels, which also interact with hypothalamo-pituitary testosterone axis. So there are a number of comorbidities which are already present. Simply seeing a testosterone level in an adult male does not qualify for a treatment of testosterone deficiency. I still remember I given this lecture in Calcutta in that अपनी जो conference करते हैं हम in July, IdeaCon. And there I've shown 3-4 cases where it is very clear, simply losing your 5% of your body weight in a patient of type 2 diabetes not only will help in control of diabetes, but improves your testosterone level and will restore your libido. So every case of low testosterone is not to be treated. Only when testosterone levels are less than 150 nanograms per deciliter, which are actually qualified as a severe testosterone deficiency. These are the cases in adult male which needs to be investigated to find out why there is severe degree of testosterone deficiency. So this is a message. And lastly, US FDA, if you see the US FDA recent meta-analysis, routine replacement of testosterone therapy in adult males is not safe. It is associated with increased cardiovascular mortality. So until and unless there are clear evidences to give testosterone therapy, it should not be overutilized.
Absolutely.
Question, Paresh Dandona and others, they have shown in diabetics a low testosterone level. You have seen those.
Yes.
Presented that paper, and they give testosterone injection in diabetics. I'm not talking about the erectile dysfunction, etc. I'm just asking for the not the garden variety of hypogonadism. I'm just asking the type 2 diabetics who have low testosterone. And do you find in your practice that the type 2 diabetics have low testosterone, many of them, and do you treat them or don't treat them?
So that's what I was telling Sambit, that after 40 years of age, there's a normal decline in testosterone levels. There is a change in SHBG levels. So actually free testosterone is a more ideal way to find out the true level of testosterone. So mild degree of testosterone deficiency in adult male should not be treated with testosterone therapy. This was an old concept when there are initial papers that giving testosterone will improve your glycemic parameters and others. But then when you see the risk versus benefit ratio, it is not favoring that all patients who are having mild degree of testosterone deficiency should be treated with testosterone injections. This is similar to like measuring DHES level. Even DHES level decreases as we ages. In West, DHEA is available over the counter as anti-aging pill. But there are papers which are published even in NEJM that routine supplementation of even DHEAs is not useful. We should not try to alter the process of aging. We should try to learn the way of living peacefully and happily with aging.
I got your point. I think Sambit, you can go to next.
Even after the bariatric surgery, the sexuality
there is improvement
improves.
In testosterone level.
That improves the testosterone level, and as Rajesh told, the weight loss. Similarly, Dr. Dandona has shown that immediately post surgery, there is a lot of improvement in sexual function and the testosterone level. So the thinner people are better people in point of view.
I wanted to ask Manisha Sambit through you regarding her comments on the perinephric abscess, which has become a big problem in many of our centers.
Yes, sir. So I did not put a slide. I put the slide and hid it because of shortage of time. So few comments. Generally, perinephric abscess is not seen as commonly as the others, but it is an important problem. And the most common organism is staph, but gram-negative organisms can also contribute. And the diagnosis is generally by imaging. And when the patient is not responding to the therapy of UTI with proper antibiotics, then you have to suspect, as I said, you have to suspect that is there some obstruction or some other underlying problem, any other abnormality, and you have to do an imaging. So that's the only method you can pick up this abscess. Otherwise, you often miss it. And whenever there is an abscess, the golden rule of medicine always applies that you have to drain it. Whatever number of antibiotics and whatever grade of antibiotics you are going to use for it, it's not going to help. So drainage is important. Drainage can be done by percutaneous nephrostomy tubes, which is very simple. And along with that, the antibiotics can be given, generally a combination of broad spectrum gram-positive and gram-negative antibiotic. And after culture, you can taper down the antibiotic as per the culture sensitivity. But drainage is the most important component.
And the route of infection is from the upper urinary tract or hematogenous?
So most of the times, most of the infections of urinary tract, even in the kidney, are ascending infections. Most of the times, around 10 to 15% can be hematogenous as well. So mostly they are ascending. So abscess can be because of both. It can be ascending, it can be hematogenous. So both can occur. So that's also important to remember. And that's why, and the thing is, like, you can do drainage, either percutaneous nephrostomy, you can put a ureteric stent sometimes if there is added hydronephrosis. And in case nothing works, then you have to go for open surgical debridement. So you have to open it out, lay out the tract open, and then remove the debris. So it responds very well. But as Dr. Das pointed out, that it's important to think of it in the first place. So most of the times we miss it. So only thing is that if the patient is not responding to appropriate antibiotic therapy, give a gap of 72 hours and then go for imaging. That is the bottom line in most of the complicated urinary tract infections.
We know emphysematous pyelonephritis is very classical of diabetic complication. We got 2 patients last year with emphysematous pyelonephritis. They had perinephric abscess accompanied. So maybe it's a extensive sepsis because of the immunocompromised host.
I think we have published case reports on this. Manisha also has seen that. It is actually nowadays, with the availability of newer antibiotics, we do not go in for a nephrectomy ordinarily. Am I correct, Manisha?
Yes, yes, it is bilateral. We don't go for nephrectomy. So as I said, it's stage 4 or not responding recalcitrant to antibiotic therapy, you go for a nephrectomy. Otherwise, if you pick it up early, most of the times you are able to manage it with drainage, percutaneous, and antibiotic therapy.
Good. I had a question to Dr. Rajesh. People think that the bald people have hypersexuality. So I see more and more people bald nowadays. So is there any relation?
You can't ask that.
So Jayant, you can ask. People can ask anything, but that it does not mean that it is always true. One has to remember this bottom line. So baldness is actually related with the testosterone level, but then the studies have shown that it has nothing to do with the systemic circulating testosterone level. It is conversion of testosterone to 5-DHT. And that depends on expression of 5-alpha reductase type 2. Now, that is a local expression in your scalp. So that has got nothing to relate with your libido. But it is good that elevates mood, that give positive feedback. So at least that maintain the sexual life. So let the people continue to live with that.
Princess Diana was biased with this fact.
So let the people continue to live with that myth.
So people don't require more hair transplantation. You will agree to me.
So I have a little one query from Madam Sai. See, Madam, males around 50-60 years, they develop chronic pelvic pain or groin pain. We do some investigations, so we do not get any positive find. Refer to a urologist. Then he does his investigations and ultimately puts non-bacterial prostatitis, cori, interstitial cystitis. He treats for 2 weeks, then again refers back to the physician. So that becomes a great troublesome for physicians, and we do not find what is there in the literature. And beating the bush we are treating, but not getting any result. That is number one. Second, the clinical issue is, in pyelonephritis, most of the organism, as you said, is gram-negative. So that is mentioned also to give aminoglycosides, particularly gentamicin. But if the creatine level is high, how to go for that?
Yeah. So, sir, answering your second question first, because it's clear-cut and easy to answer. So, gentamicin and all we can use, I mean, even in renal failure patients, even in patients on dialysis also we use them, but we modify the dose and give. But nowadays we generally don't need to use these drugs very often because of availability of other drugs which have the same spectrum. So you have aztreonam, you have piperacillin, tazobactam combinations, you have carbapenicillin, which have similar sort of spectrum. If you still want to use the aminoglycoside, you can remember the formula NG-TANS. NG-TANS means it stands for which one is the most nephrotoxic, which one is the least nephrotoxic. So, I mean, the amikacin that can be used, it has less of nephrotoxicity. You can use gentamicin also. So avoid neomycin, those things anyhow we don't use, we use only topical. So those things we avoid, but amikacin, gentamicin, we use them quite often. We use them alternate day single dose therapy. We don't give a BD dose, but we use them as a single dose therapy because the concept is aminoglycosides, the peak concentration is important. So if you give the same dose divided in 2 different doses, it won't reach that peak and the organism won't be killed. So whenever you are modifying the dose of drugs, you have to know which organisms respond to the peak dose and which antibiotics, they have a peak level effect. So these antibiotics, they have 2 important properties, the aminoglycosides, that the peak level is important. So give full dose at one time and then give it alternate day rather than splitting the whole dose and giving it daily twice. So that's one important principle. Other thing is they have a post-antibiotic effect. So you give the dose, their antibiotic action will last for 48 hours. So if you want to use aminoglycosides, please go ahead and do it. But as I said, alternate day single dose is better rather than giving it 5 doses. Coming to the first question. The first question is again, as you said, it is a common problem for nephrologists as well, because this prostatitis I have today dealt with acute bacterial prostatitis. Prostatitis is not simple. It has many other presentations. One of them is chronic non-bacterial prostatitis. And this is one entity which is difficult to treat. You have to use so many relaxant measures, sometimes instillation of therapies, bladder washes, muscle relaxant drugs, tramadol. So all these non-specific treatment is recommended for chronic non-bacterial prostatitis, meditation, bladder relaxation. So many other non-bacterial therapies are indicated. And as you said, it's a tough nut to crack. As of now, the specific therapy for the so-called chronic non-bacterial prostatitis is not there. One which can solve all your queries is not there. It's a combination of so many things, including the sedatives, painkillers, washes, bladder relaxant exercises, so on and so forth. So those things are important.
Thank you. Thank you, madam. That was a very important answer. So coming to the fag end of our session, I think we are
it's time 2 minutes more.
Yes, sir. I think we are running late. So we'll wrap up the session. Already I got the message from Alok sir. So